Yeah, good morning to those who join with us from Estonia and around, and good afternoon to the rest of the participants from Asia, including Sri Lanka. So my name is Dulmini Nanekar, a research fellow in the Estonian University of Life Sciences, and I'll be the moderator for today's events. So today I'm thrilled to welcome you all for the guest lecture by Professor Veranja Liyanapathirana from Department of Microbiology, Faculty of Medicine, University of Peradeniya, Sri Lanka. So Professor Veranja Liyanapathirana is a microbiology expert at the University of Peradeniya, earned her medical degree in 2006 and later dwelled into research, obtaining an MPhil in 2011, pursuing doctoral studies in pneumococcal studies at the Chinese University of Hong Kong from 2011 to 2015. She expands her focus to antibiotic resistance and molecular epidemiology. Now, back in Sri Lanka, she is actively securing grants to establish molecular detection methods for antibiotic resistance. Her primary objective is to develop community-centric studies, the strategies to curb the spread of antimicrobial resistance. And she is the mentor to me, and I learned all the ABCs of research from her back in 2015-16 time during my master's. So today she's gonna talk about antimicrobial resistance, developing country perspective to the silent pandemic. So over to you, Professor Veranja.
Thank you very much, Dulmini, for that very kind introduction. And also thank you for inviting me to this event, which I think is a very important one because you all are talking about a wide variety of topics with people from different areas. And that seems to be giving a very nice perspective of everything, a little bit of science from here and there, building up into a very big picture. So I'm Veranja Liyanapathirana to everyone who doesn't know me, and good afternoon from Sri Lanka, and good morning to everyone who's joining from Europe. And I'll be talking in the next 30 to 40 minutes about antibiotic resistance and developing country perspective. Now, I've included developing within inverted commas because that's a term that is being challenged, and there are so many other terms that are coming up to replace that. But in a way, we are from developing countries. So I hope my slides will move. Yeah. So first of all, this is a personal perspective and a reflection based on available evidence from where I come from, Sri Lanka, and from other countries that are considered to be developing countries, global south, or low and middle income countries, whatever the way that you would like to call it. And it is not in any way intended to undermine the existing strategies that are in place to curb antimicrobial resistance or the research endeavors. So if there's anyone who is not coming from a microbiology background, this is just a very basic introduction. Antimicrobial resistance occurs when microbes or organisms that cannot be seen with the naked eye develop resistance to drugs that are regularly used to treat them. Now, antimicrobial resistance is actually a natural phenomenon, but the misuse and overuse of antibiotics has escalated this problem because, as we all know, when there is a threat, the organisms that have the arsenal to overcome or thrive in the presence of that threat will expand. And this, coupled with improper adherence to basic infection control precautions in hospital or healthcare settings and lack of hygiene in community settings, has led to spreading of these resistant bugs in the society, both in the community as well as in healthcare sector. Generally, overprescribing of antimicrobials or antibiotics and patients not adhering to the regimes in healthcare are major drivers of antimicrobial resistance. However, it is not only the human healthcare sector that contributes to this. A misuse of antibiotics in other sectors, in livestock and fish farming and in agriculture, also contributes to developing an emergence of antimicrobial resistance. And once it develops and emerges, the spread, as I mentioned earlier, is facilitated by poor infection control and lack of hygiene. Now, another confounder, particularly in the developing countries, is even though these may have been there for a long time, we did not have the capacity to actually pick these bugs up. Therefore, the lack of diagnostics actually had led to these bugs spreading in our communities without us actually knowing them. And of course, many parts in this side of the world are hotspots for travel, and this tourism has now made these bugs to spread to other countries also. So anything that happens in a developing country is not isolated, as we saw with the COVID-19 pandemic. Any infection that happens anywhere in the world, it is only a matter of days and weeks till it comes to another side. And of course, so far I've been talking about the human side and a bit about the animal side, but the microorganisms in themselves are clever beings, and they are the ones who are primarily evolving in response to us misusing antibiotics. So the microorganisms also contribute to that, but we drive this process. So most of the initial antimicrobials were actually derived from natural products. And therefore, organisms that could resist these were there in the community. So, as when the antimicrobial compound came into use, those organisms that have the arsenal to fight that emerged. So, as you can see in this figure, almost every antibiotic being introduced to practice was closely followed by identifying the resistant variant to that particular antibiotic. But what has happened in the recent past is, if you can see the right-hand side of this figure, the time gap between the introduction of a particular antibiotic and the emergence of resistance has reduced quite drastically, I would say. Why? Because as soon as an antibiotic now is licensed, it's widely used. And of course, antimicrobial resistance started, even though it has been there and people have been discussing about it in health sector, in veterinary sector, and in microbiology world, it started to make headlines towards the end of 2010 or somewhere around that. And now it is regularly making headlines in global arena also. And if you look at the statistics, this is one of the commonest slides that we use in trying to communicate the impact of antimicrobial resistance. If someone gets an infection with a bacteria or a microbe that is resistant to an antibiotic, there's more likelihood that that particular person will go into complications or will die. And at the same time, treating these patients who are infected with antimicrobial resistant bacteria or other bugs are very costly. They need to be staying in hospitals for a long time, and they have to be given other therapeutic modalities and antibiotics, of course. Therefore, there is increased health associated cost. However, despite these statistics, antimicrobial resistance is still silent. Just like global warming and climate change, which are also considered to be silent pandemics, even though we are now starting to feel it, antimicrobial resistance is also not felt. Simply because, I'm sorry, my examples will mostly come from human health side because that is where I'm more familiar with, but I think this is the same for other health sectors also, in vet sector and in agriculture also. Now, we don't feel antimicrobial resistance because, especially when it comes to humans, we consider causes of deaths of patients and we attribute them to diseases like cardiovascular disease, pneumonia, or myocardial infarction or heart attack. We don't attribute causes of deaths to pathogens. Even if we say someone died of pneumonia or meningitis or a brain infection, we don't talk about the underlying bacteria or virus or whatever that is causing that. And in certain cases, we might be attributing it to the pathogen, but still we are just talking about a pathogen, not about the antimicrobial resistant variant. This actually led us to not feel antimicrobial resistance that much. Therefore, this increasing mortality, morbidity, and healthcare costs, those are also not so much attributed to antimicrobial resistance, at least till the recent past. Now, this has had far-reaching consequences. The fact that we have let this spread so far is having far-reaching consequences, because it is not only infectious diseases that are becoming more difficult to treat, even other healthcare advances like transplants, implants, cancer treatment, all these are becoming very difficult to sustain, because most of these invasive procedures and treatment where immunosuppression occurs are dependent on the availability of effective antimicrobial therapy. That is why antimicrobial resistance is so important. It is having far-reaching consequences, not only in infectious diseases, but in other healthcare areas also. Now, in the next couple of slides, I'll be briefly talking about the burden of antimicrobial resistance, awareness about it, consumption of antibiotics and prescriptions, the commitment we have to curb them, causes of AMR, the solutions, and a bit about a double-edged sword. And I might be taking global perspectives, lower middle income country perspectives, so sometimes where evidence is available, I'll be taking you through the evidence coming from Sri Lanka. So I told a while ago, just a couple of minutes ago, that we haven't felt antimicrobial resistance because the data was not attributing to antimicrobial resistance. So for the first time in 2022, there was a paper that actually calculated the burden of antimicrobial resistance and quantified it from data coming from 2019. And according to that, there are 4.95 million deaths that are actually associated with antimicrobial resistance in 2019. And the attributable deaths are also quite high at 1.27 million. Now, when you consider diseases, most of the most burdensome diseases have been things like pneumonia, that is lower respiratory tract infections. And this study also identified key pathogens that contribute to this mortality morbidity, that is drug-resistant E. coli, Staphylococcus aureus, Klebsiella, Streptococcus pneumoniae, Acinetobacter, and Pseudomonas aeruginosa. So these are common names that anyone who at least even walks into a hospital will encounter these days. And in 2016, there was another quite well-known a report which was commissioned by O'Neill, and this actually showed that impact of antimicrobial resistance, even though there is a global impact, etc., there is a disproportionate effect of this in lower middle income countries, particularly in Asian region. So still, even though there is postulates and some sort of data coming from low middle income countries, even the paper that I cited 2 slides ago about global burden of AMR highlights that there is lack of data or scarcity of data coming from many lower middle income countries, and they highlight this as an important limitation of their work. So there is actual lack of high quality data that quantifies the burden of antimicrobial resistance in low and middle income countries. There are some studies like the bloodstream infections, Enterobacterales bloodstream infection study that is coming from one part of the globe, where they interestingly found that in bloodstream infection, the resistant and the sensitive phenotypes did not differ in the outcome. Now, this is an interesting finding. It contradicts what I've been talking about earlier, but this paper also opens up a lot of questions as to, was there anything that is happening in the community before people actually seek healthcare that might have given rise to this data? So there is still a lot of things to explore, because evidence, when it is available, is sometimes contradictory. And there is this quite interesting systematic review, which is also quite recent, which has reviewed studies again from low and middle income countries about bloodstream infections caused by antibiotic resistant bacteria. The important thing here is, yes, the findings are there. For those who are interested, it can be read. But the important thing here is they have actually looked at 109 papers in the end. And of the 109 papers, 96 have been from middle income countries, even though their title is low and middle income countries. majority had been from middle-income countries. And even of that 96, 49 had been from one country, that is China. So this highlights the fact yet again that we need to have more data about the actual impact of antimicrobial resistance from lower middle income countries and low income countries. And this study also highlighted that when considering the different WHO regions in the world, the CRO regions where I'm coming from has the least amount of studies. Of course, there are some good things happening in parts of the world also where people are trying to quantify antimicrobial resistance as a starting point. So the WHO GLASS surveillance program is a good starting point. As shown here, many countries have started to, provide data for that. This framework is looking at both antimicrobial resistance as well as antimicrobial consumption. So if you want to get some data about different countries, this is a place to go to, and we can go through their outputs and identify resistant rates for selected organisms from selected sites, as well as about consumption data from some countries. Still, there are issues with this system also because people are citing questioning quality of data, and there's lack of staff, particularly in lower middle income countries, who can dedicate time to feed data into these systems, because some of our countries don't have automated laboratory reporting systems that can be linked to such databases. So this is a good start, though. We hope that it will evolve so that the data about antimicrobial resistance and antimicrobial consumption and their impact could be made available for anyone to access. Okay, let's look at some things coming from our country. We know that our antimicrobial resistance rates are quite high from isolates in patients coming with clinical infections, not only in hospital-acquired infections, but also antimicrobial resistance rates are quite high in patients who are presenting to hospital with community onset infections. There are quite a lot of studies that have identified them. Next, many groups, including ours, will be included, have looked at healthy people representing the community to see if the normal flora they are carrying is having significant percentages of antimicrobial resistant bacteria. And all across the country, we have found in different populations, pregnant women, university students, and people handling animals, animal husbandry, and organisms colonizing children, antimicrobial resistance is quite high in our normal flora. And of course, in some livestock animal also, antimicrobial resistance has been quite high. So we know that colonization with resistant bacteria is present both in healthy people as well as hospitalized patients. And infants are becoming colonized immediately after birth. And there are studies that demonstrate that colonization rates are higher, obviously, in urban areas than in rural areas. And of course, resistant rates are quite high in certain significant populations, like in the elderly, but sometimes those rates are not so high. And of course, resistant bacteria, they are among both domestic and wild animals, and also in the environment, though I haven't presented those papers in here. But now here, the gap in research is, what is the outcome of this colonization? How many of these resistant bacteria will go and cause endogenous infections in people who are colonized? And how many of these people contribute as a reservoir to cause resistant infections in other humans or animals, or to spread in the community? So these are the things that we have to study a bit more in our communities. And of course, we have studies that have looked at the molecular epidemiology of isolates that are here. And initially, this was a very exciting thing, looking at molecular epidemiology, identifying the genes, identifying whole genome sequences, comparing them globally. But after a while, you start to realize that, hey, we have also got the same clones, the same plasmids, the same resistant markers that everyone else has got in the world. So we know that we have them, period. So the gap here is, what is the real world burden and impact of infections with resistant bacteria, because we don't have outcome studies of infections caused by resistant bacteria. And we also don't know the real world outcome of colonization with resistant bacteria. And where is this coming from? Has it become endemic? I think it has. But even if it is endemic, what is the main reservoir? These are things that we are yet to identify and elucidate. So let's move on to awareness. Now, these are some posters that might be quite familiar to at least some of you in the audience. We share them, all of us share them. They are coming from different institutes like WHO, CDC, or whatever. And every year we have an antimicrobial awareness week, which is doing a great job because at least for 1 week in the year, we talk about antimicrobial resistance. And there we talk about what causes antimicrobial resistance, how to spread that, etc. Now, quite a while ago, we thought, okay, let's see if our population knows about antimicrobial resistance. And we did a questionnaire-based study. Of course, they didn't know about antimicrobial resistance. That was sort of expected. But boasting what like one of the better or best literacy rates in Asia or in the world, we were quite surprised to find that let's leave alone antimicrobial resistance, but our community doesn't know what is meant by an antibiotic. So we were quite taken aback. Then we did another study where we actually asked people whether they knew what an antibiotic was and asked them to name, state what they think an antibiotic was. And there, when we analyzed that data qualitatively, we found that even though people who think they know what an antibiotic is, the understanding of what an antibiotic was quite poor. Only like half of the 200 odd people who participated were able to define what an antibiotic is. Now, mind you, these are people who were literate, who were answering questionnaires in English, and who were capable of using an internet device. Even in that community, the awareness was quite low. And we also asked them to name drugs that they think are antibiotics. While naming some commonly used antibiotics, we were quite surprised at the beginning to see that people were naming general day-to-day drugs like chlorpheniramine, even paracetamol, antihistamines like cetirizine, domperidone, aspirin, even insulin, sometimes traditional medicines also as antibiotics. So and then we actually checked a couple of other community school children whom we thought might be, actually being educated about this in school, especially since we scrutinized the curricula and found out that they were being told what an antibiotic is, etc. Again, the awareness was quite low. And it's not only us, other studies done in Sri Lanka by other researchers have also identified the same thing, that people were actually identifying drugs such as paracetamol as antibiotics. So this means that for us to start awareness programs, we need to go a step below. We can't start our awareness programs with introducing antimicrobial resistance. We have to introduce an antibiotic or an infection before we can actually start introducing antimicrobial resistance. Right, with that, let's move on to consumption of antibiotics and antimicrobial prescriptions. Now, I said increased consumption lead to antimicrobial resistance. So there's a Sri Lankan national survey on antimicrobial consumption from data from 2017, published in 2021. There they have highlighted that according to a reference quantification of antimicrobial consumption, we have quite high antimicrobial consumption. And in our health sector, which has a free state-funded healthcare arm as well as a private sector arm where patients pay out of pocket, when the antimicrobial consumption of the two groups were compared, majority of the antibiotics were being dispensed in the private sector, way over what was given in the state sector. However, mind you, majority of the healthcare is provided by the health sector even now. And okay, there are some point prevalence surveys in health sector hospitals where they have found that, again, there also antimicrobial use is quite high, and the highest has been in one particular survey from surgical units. And then we went and analyzed antimicrobial consumption in another tertiary care surgical unit where we found that, yes, antimicrobial consumption is high. And interestingly, people are using antibiotics in very acute conditions, and Also, the indications for using antibiotics, etc., are not actually clearly documented. So, when we are to establish what is known as the stewardship program, which will aim to regularize antimicrobial use, we have to again start at a very, very basic level, not at a level where people expect us to start, but way below that, because we have to start even by improving the documentation of prescriptions. There are some interesting studies about antimicrobial use for respiratory tract infections coming from south of Sri Lanka. Now, respiratory tract infections like common cold are usually caused by, they are most of the time, 99.9 of the time they are caused by viruses, which, as we all know, do not need antibiotic treatment. And there are no antivirals to treat common cold either. However, in a survey that was conducted in south of Sri Lanka at an outpatient department, they have found that nearly 35 or 36% of the people who were going for treatment as outpatients were given antibiotics, and most of them were given antibiotics for mild respiratory infections, which are most likely to be viral in origin. And the other thing was that among all these patients, only a limited number of patients who were given antibiotics had undergone diagnostic testing. This highlights the lack of diagnostics, the lack of availability, and also, even when available, the lack of use of antibiotics. Diagnostic testing, which in a way promotes antimicrobial use. And the same group, when they have identified this interesting thing about using antibiotics for respiratory tract infections, has done a qualitative study which has revealed some very interesting things. For example, patients go to the outpatient department accompanying someone else. And then when they feel like, I might be getting a respiratory tract infection, they might go and tell the doctor, I have these signs and symptoms, so please give me something. That has been actually found in this study, which is nicely documented. And now those patients, even though they wanted it, their expectation has not been for an antibiotic. Their expectation has been for some medication that will relieve them of symptoms. However, when you actually talk to the prescribers or the medical community, we most of the time think that patients demand antibiotics. They expect a capsule or an antibiotic. So what the patients actually are expecting and what the medical community thinks the patients expect is completely mismatched. Now, of course, we shouldn't be giving things just because patients expect it, but this is a commonly cited reason, not only from our country, but from multiple other countries for prescribing antimicrobials, particularly for respiratory infections. So this is quite an interesting finding. And recently at Kandy Hospital, at the community in Kandy district, the same sort of a study was replicated, where again patients have said they are going for treatment after about 3 days of getting respiratory infections, but they are not expecting antibiotics. The majority, they want something to relieve their symptoms. And they have also said the majority of these study participants were going to what I mentioned earlier, the private sector for treatment. And in the earlier consumption study, we could see that majority of antimicrobials in the country were being dispensed in the private sector. Right, so that is about the practices, but what about the prescribers? So prescribers, their knowledge has been quite good in the few studies that have been done, but the translation of that knowledge into practice and the confidence has been found to be quite lagging. So this is something that we need to improve as a country in Sri Lanka. And I was reading in other countries also, this is quite similar. What about other communities? We know other healthcare professionals. We know it is not only the doctors who contribute to antibiotic use chain. So studies have been done among nursing officers, among pharmacists, where again, in most of these communities, knowledge had been good, but despite having knowledge, sometimes the perceptions or attitudes needed certain changing. And the other thing that was found is that in certain countries, including ours, antimicrobial stewardship, as prescribed, in textbooks or as prescribed by organizations like the CDC or the WHO is quite unlikely to be taken for the face value as it is, because healthcare structure is different, healthcare hierarchy is different. It needs to change. But to make those changes, you have to do a slow change rather than a very drastic change. So stewardship activities, when they are being implemented in countries like ours, need to be adapted in culturally appropriate ways. Well, antimicrobial overuse is not, of course, restricted to healthcare in humans. As I mentioned earlier, this is a graph, this is a map of the world which indicates quantifies the antimicrobial use in animal husbandry and the quantities used, and we can obviously see where the highest amounts are being used. Again, this is a problem that has to be addressed globally. What you can see is that if you actually take the lower middle income countries, you might say that their overuse is not bad as compared to some of the middle or higher middle income countries right now. So points to ponder. So with that, let's move on to commitment. Now, commitment to overcome antimicrobial resistance has to be there in different ways. So, maybe a good starting point would be actually trying to quantify our data and share our data with data sharing streams like the GLASS system. And there's this interesting study from BMJ Global Health where they have looked at very high-level meetings, United Nations meetings, the World Health Assembly, FAO meetings, etc. since 2015 up until 2021. They have looked to see whether antimicrobial resistance has been given any priority. So the first column here, let me see if I can get a pointer. So the first column here, gap 1, is education and training. And gap 2 here is research and surveillance. Gap 3 is sanitation and infection prevention. Gap 4, optimizing the use of antimicrobial. Gap 5 is sustainable investment for these tasks. So if you look through here, now ash means zero mentioning of that in the meeting, and dark green is, it has been discussed over and over again. You can see education and educating the public about this issue has got the least of the attention, whereas gap 2, which is research and surveillance, has got quite a lot of attention, as well as gap 4, which is optimizing antimicrobial use. And as expected, sustainable investment has not got much attention. So, and unfortunately, even sanitization and infection prevention has not seemed to get much attention. So research seemed to get a lot of attention, but not so much the other areas. And, again, I will not comment on it, but these are points to ponder. Of course, research is needed to drive fundamental changes, but, research alone will not be able to impact upon antimicrobial resistance. So similarly, most countries in the world have a national action plan on preventing or on combating antimicrobial resistance. Now, the second phase of action plans are being developed or have been just developed in most countries. And in 2023, there has been a look at the national action plans by a research team. This was published in Lancet Global Health, and they have identified that certain areas in the of these action plans have much room for improvement. This is again a good paper for anyone who is interested in public health to read. Right, so we were talking about burden awareness, consumption, prescription, commitment. Now let's move on to causes. Of course, we dwelled on causes a bit earlier. Right, we know overprescribing and patient lack of compliance, overprescribing in animal husbandry, poor infection control, lack of hygiene and lack of diagnostics, all these lead to antimicrobial resistance. But looking more closely at lower middle income countries, there are more crucial things like lack of access to wash facilities, both not only for humans but to animals also. poor infection control and prevention protocols, not only in healthcare facilities, but also at homes and farms. Poor access to quality and affordable vaccines, diagnostics and medicines, lack of awareness and knowledge, and lack of enforcement of relevant regulations. These are more specific to developing or low middle income countries. What about then solutions? Is there a fit for all solution for antimicrobial resistance? Is there a single solution? Can the global north dictate solutions to the global south, or can the developing countries or overarching institutes, say, okay, as developing countries, you have to do this? No, because as I've been trying to highlight, there are some things that are quite different in our countries that need specific interventions that are homegrown, and we have to be able to adapt these culturally. Right, let's move on to access to antibiotics. Now, antimicrobial resistance has been made even worse because of the drying of the pipeline of antibiotic development. Now, antibiotic development is not getting very much attention globally. With that, let's also look at antibiotic use. Now, this graph shows that over the this is actually from 2000 to 2015, the antimicrobial use in high income countries has more or less remained the same. Whereas in lower and lower middle income countries, it has risen a bit, and upper middle income countries, it has risen a lot. Now, when you consider low and lower middle income countries, we have to question, is it simply because of misuse, or is it because they are getting access to some antibiotics that were not previously accessible to them? So when we are interpreting charts like this, we have to always be mindful, because in most lower income countries and lower middle income countries, even though antimicrobial resistance remains a problem, lack of access to quality antibiotics is more of an issue than antimicrobial resistance even now. Therefore, access to antibiotics and limiting access to antibiotics has to be done in a well thought through manner, again locally adapted. We have to restrict overuse and inappropriate prescriptions, and we have to restrict over-the-counter availability of antibiotics. But while doing that, we have to ensure availability of antibiotics of proven or suspected infections, adequate access, equitable access, and access to quality assured antibiotics. Therefore, these regulations have to be prudent and custom made for a given country. Now, the last couple of slides is looking at other problems that low middle income countries or developing countries are facing. Now, this is a very interesting modeling study. I'm sure most of you have seen this, where they have seen that average antibiotic resistance, which they have looked at a number of isolates and proportions and modeled that, the average antimicrobial resistance has been correlated to control of corruption. So countries with well-controlled, controlled corruption or less corruption have had less antimicrobial resistance. And of course, countries where control of corruption is not so good has had high level of antibiotic resistance. Again, this will impact low and lower middle income countries. And globally, as well as mostly in low and lower middle income countries, antibiotics have come this far to be misused and abused because it has been used as a quick fix to fix cracks in different systems, cracks in healthcare, cracks in hygiene, cracks in productivity. People are not given days off to rest, so they try and medicate themselves on antibiotics, assuming they will be cured by that, even though all what they need is a rest. So using these antibiotics as a hinge to, either intentionally or unintentionally to hold on corrupting systems have led to antibiotic resistance escalating as a major issue. And we have to look at this now And we will also need to identify the cracks in our own countries and find fix in our own ways. Now, this is my last slide. What is the role of a researcher from a lower middle income country when it comes to antimicrobial resistance? Of course, lab-based studies are what we are most attracted to. That gains us the most professional satisfaction. Papers, and it will give us more grants, more recognition. And most of these work we do on isolated organisms, on isolate characterization, etc. But so far, we are not dwelling, at least in Sri Lanka, we are not dwelling into looking at the impact of these isolates. That is where we have to head to. And, we actually need to do clinical outcome studies. Again, we are not dwelling into those. Now, I feel personally that we have to look more and more into educational studies and behavioral changes studies and purely looking into lab-based studies. Unless we look at these behavioral changes studies and advocate to policymakers and do those effectively, simply doing lab studies is not going to be helpful because the bugs are evolving and it has evolved so far and gone into the future. We know they are evolving because many people are working on this even in other countries, but we need to now as scientists come out of our comfort zone of being inside the labs and try and see what we can do to actually change practices. Right. So with that, I will end my talk and thank you once again to Dulmini and the team for giving me this opportunity. And thank you.
Thank you, Dr. Veranja. So now the floor is open for questions. Do we have any questions? Yeah. So until they get ready, let me go with my question. Educating the society is my major concern in all this time. And I felt like what is the best level that you can educate? To me, I feel like if we can go with the primary school, secondary school education system, like that's where I feel like we should introduce the very basics and then educate them. Like how's your thoughts regarding this?
Thank you, Dulmi. It's a good question. I mean, first of all, I don't actually have an answer because I'm not an educationist. All I can say is, yes, we have to educate. So we have to get the experts from the education sector involved. We know the messages that have to be given. Yes, we do have to maybe start from preschool level, etc. But how best to communicate that? If we are the ones who are designing the educational material also, that probably will not really be communicative. Maybe that is one of the reasons that messages were not getting across to the community. The way small children will perceive things are different. And again, when they're coming from our culture, how they perceive things are different. So we need to develop materials which are sustainable to them. And of course, start at very basic levels, like you said, in schools and even in preschool levels, just introducing maybe to germs and saying, start by washing your hand, unless other than cramming educational things into that level, and then gradually building up impactful educational material that are not exam driven. I don't know, so we really need to have a wider discussion about this with educational experts.
Is there any more questions? Yeah. And then there's one more. I understand that we spend thousands of dollars, rupees, euros, when we'll go for like multi-million grants, but then what could be the end?
I don't know, apocalypse. Not really, I think. So we have to take a step back and, even though I painted a bleak picture, it's not that bleak. So there are solutions we have to make sure our health systems are in place, we have to make sure that our vaccination programs sustain because prevention will be the key thing. right? So vaccination program, we should be really, thankful and proud of that. That is controlling a lot of bacterial infections and viral infections, where secondary bacterial infections with resistance can contribute to issues. So we need to sustain those things. We have to sustain our basic infection control. And we have some good practices culturally coming, like, boiling water, washing hands, etc. So those have to be re-emphasized. And who knows, we have traditional medical systems, maybe those can be tapped in and actually uh, explored in a scientific manner. Even though I haven't touched on, a lot of people are testing traditional materials and even nanocapsulating them using new technology to see if then they can be moved as treatment, re-exploring phages. All those are done at a preclinical level. So, our research funding, instead of just characterizing organisms, and that if that those can be, if the studies that have stopped at preclinical stages can be moved into the next stages, those are probably things that we can do also.
Yeah. So Suranga, please go ahead.
Thank you, Veranja. Thank you for the interesting talk, and I really enjoyed. Just in the perspective of in the molecular biologist perspective, when you look at this, emerging of this AMR, I mean molecular level plus, when you even look at the incidence, for example, let's say, for me it's always hard to understand. Okay, we have AMR, and it's a serious case, but exactly like you said, we don't really know whether the outcome is really matching the level of AMR that we see. Like, for example, it's there, it's been there, it's kind of, I don't know, but that's part of our whole evolution that yeah, because obviously because the bacteria, they have, short life cycles, they're prone to have mutation, they have simple genetic structures. So, but well, if you look at, for example, especially if you look at the animal antibiotic use, it had been there, like, I don't know, from 50, now it has been used as first growth promoter, but now it has, got some restrictions. Especially this part of the world use a lot, like in early 50s, 40s, 30s, even if you look at the use of them. But now actually we see it because there have been some regulatory affairs. But I don't know, what's your perspective? Like, for me, I'm really trying to see, yes, like you said, maybe the cause of death of a person will not attribute to the AMR, like exactly like you said, it could be something else. But how can we really still have a difficulty of getting the perspective of the cause and the outcomes, like what's your idea, like could it be a part of, like, if somebody say it's like part of our evolution or something?
A good point, Saranga. There are people actually talking about that also. Yes, our normal flora evolves with us, like particularly slow growers like Mycobacterium tuberculosis are shown to evolve with evolution of humans among different, the lineages, etc. So for these rapidly growing ones also, I don't know, I haven't looked at that aspect actually. It could probably be part of evolution also, because resistance is driven by by strengthening their ability to survive. And on one side, when their resistance is increasing, sometimes their fitness cost is too high and they die off. So it's always that balance in nature. So actually quantifying the impact and also respecting our immune systems, and vaccination, boosting immunity, those things, because those will help to prevent, and then we'll have to really go into identifying the impact. And I also don't know, just as you say, because the numbers are so high, it has been there for a long time. The impact is severe in certain areas which we don't see, particularly in cancer care, in transplants. There, the impact is very severe, and we
But
don't
obviously
see
it's like co-founding, like the reduce immunity, all these things also contribute, like, so
they also contribute, but effectiveness of some of those things that we are holding on for life, like putting a prosthetic hardware, replacing a joint, those are coming under pressure. we might not be able to sustain them for a long time. So like, all this time, simple procedures were effective because we were using prophylactic antibiotics.
Yeah, I
When the
agree.
prophylactic, so things like that like we still don't feel it. So actual tangible data and how to present data tangibly, there are also things that we'll have to start thinking of. Right?
Yeah.
Thank you, Veranja.
Okay, thank you.
And there's one more question. So in part of the world, like those who are dealing with GBS, we were fighting to give the reason for stillbirth, like kids that they die before that term. Or we consider them as stillbirths due to GBS. Issue them that certificate mentioned in the reason. Like we were shouting for that since past few years. And like in the same way, is there any discussion regarding the deaths due to AMR?
So, like again, the way causes of deaths are written is from a prescribed, we have to, you write the cause of death using an ICD classification. We need to use the exact word. So, I don't know. So, I'm not very sure. I'm not aware whether people are, talking at that level, maybe to get those changed. But right now, we are still using the ICD classification and saying, this person died of pneumonia. But, if you go later into the details, into clinical details, not in the death certificate, but in the records, ideally the cause and the ABSTs should be there. But I don't think there may be voices going that way. I haven't actually come across that till me. Yeah, but things to think about to make it more felt.
Yeah. Okay. Thank you so much. And is there any more questions to Dr. Veranja? Okay, if not, then I would like to thank you very much for spending your time and your valuable ideas with us. And thank you all the participants for joining with us. We will be sending the link. You can go to our YouTube channel after a few days. Then you can re-listen to this talk, and I will share it. Ursula will share the link with the possible medias like Instagram, Twitter, and all, so that everyone can re-listen the talk. And thank you very much. And thank you very much, Professor Veranja, for joining with us today. And we would like to see you in future collaborations.
Thank you.
Yeah.
Thank you,
Thank you
everyone.
very much.
Bye.